Oh, and we already got the slide up. I'm Lloyd Michener from Duke, from Durham, and from the Practical Playbook, a national group to really work with communities to improve health. And what I'd like to do is share with you this national movement, which is way underway and moving really quickly, to make a difference, to actually act on that data and show what we can do. This is the old slide set. We shifted back. Okay, we've talked about Carl White's data about healthcare occurs in the community. And it's really based in that, but I finally realized that this slide actually is a little bit misleading in a funny way because it actually suggests that our communities are similar, or at least can be put in similar boxes. But in fact, as healthcare data becomes more readily available, public health data, we're finding our communities are staggeringly different. Now, if you live there, you might know that, but the availability of data as the American Cancer Society actually shows, for instance, colorectal cancer in the United States has shifted in the last 20 years from being broadly distributed across the U.S., especially the East and Northeast, to really being in 3 hotspots in the United States. Where you live really does matter, including for things like cancer. So we're finding that variation nationally. We're finding it within states too, and the states are really paying attention to this because of the premature death, because of the loss of productivity, and because of the cost this represents. This is an all-payer database analysis of Virginia. There are 7 standard deviations in the frequency of stroke from Northern Virginia to Southern Virginia. SES matters, race matters, but none of that explains that pattern. It starts in Roanoke and it sweeps out to the sea. We don't know what causes it, except a river runs through it. The Roanoke River starts in Roanoke and goes out to sea, and that same pattern continues into North Carolina, where we're paying attention to it because of the cost and the loss. But also, we see that pattern within cities. This is a recent analysis, shared all these with permission. Montefiore did, because it has an ACO, it takes care of a lot of Medicaid patients, but Montefiore didn't realize till they looked at their own data that the prevalence and frequency of visits of kids with asthma to Montefiore had a 300-fold variation depending on which apartment complex the kids came from. They went out and talked to the community and said, well, we know that because our kids in those hotspots are missing school 40% of the time. We're already working on this. We actually have a legal coalition. We're suing the landlords to clean up the HVAC systems. But between Montefiore and the community, they've care managed, they've coordinated, and they're reporting a 90% reduction in asthma admissions. This stuff is powerful. Part of the issue, whoa, that's a lousy one, is that the communities often can't make sense of all the signals they get. This is actually all the housing code violations of a big swath of Cleveland. You go, oh my God, it's almost every housing project in that part of the city. What you can't tell on this slide is that 4 of those dots represent most of the asthma COPD admissions. They actually go in there, and there's a little picture up there. Those 4 are covered with mold floor to ceiling. That's a housing code violation, not a healthcare cost. We're doing with the Build Health Collaborative intervention study, see what we can do on health outcomes improvement. We think we know the answer to that. But it's now a national movement. RWJ with CDC is pushing out data at the census level track for 500 cities. Anybody here live in a city that's on the top 500? Yeah, 1 or 2. So the data is now available. It's public health and often medical data. This is Durham, North Carolina. It shows patterns that those of us who live there have known, but it shows a concentration of uncontrolled hypertension in this map in our poor black community. But other maps show patterns we didn't know. In particular, there's a cluster of cancer in a more less poor, but much more rural setting that might actually be related to a Superfund site that's near there. So they're patterns that sometimes tell us what we thought we knew, and sometimes they tell us things we didn't even suspect. With that data, with coalitions, you can really make a difference. This is an early study we did, wrote up in Health Affairs, where we actually found with our Medicaid program, we had a whole bunch of very low-income women living in a senior high-rise. They had an average income of $7,000, 25% went to rent, so they're living on $5,000. They all had primary care docs. They all had medical homes, folks, and we never saw them because these folks, 44% major psychiatric illness, they couldn't get to our office. So what we did was actually talk to them, listen, that was the hard part, and actually bring care to them with a geriatric social worker, NPPA, backed up by a family doc. And in 1 year, we saw inpatient utilization drop 68%. Now, real quick question, the 80%, 60%, what sort of effect size is this, and what compares to that? The only thing we have in our entire medical and public health armamentarium that has an effect size this size are vaccinations like polio. So this sort of coordinated intervention between medicine and public health using data has an effect size as powerful, or reaching the power of the best things we know out of American and international medicine. They've scaled, this is an example recently published from Boston Children's. They have a similar coordinated program using data, 80% reduction in asthma admissions. 80%, folks. It's growing fast. Academy Health did a study of this, 450 community partnerships, community public health partnerships, often with health systems, rarely with primary care, are underway in this country. They're underway in almost every member of this community, of folks here. What we've learned is that process matters. You got to do this in a systematic ways. The partnerships really matter. It's multiple sector. Legal's there, but so is public health, so is the schools, communities. Actually, let me skip that for time. It's something we should know how to do because it's in our roots. The Willard report that establishes, talked about working in the family and the community. It's in our future. Health is primary. It's part of our mission. Please join the movement. It's underway in your communities. And God, folks, it's the most fun, powerful thing I know how to do. Thank you.